Dr. Howard, thank you so much for joining us on MD Newsline podcast. Can you please introduce yourself to our audience?
Yes, and thanks so much for having me. So I am Fred Howard. I'm a breast oncologist at University of Chicago, and I also run a research group focused on the use of AI, mainly for biomarker development for breast cancer.
hmm And for listeners who may not work with AI on a day to day basis, can you talk to us a little bit about what artificial intelligence means in the oncology landscape and just give us just a general idea of what some of the tools are that exist in your world?
Yeah, I mean, artificial intelligence is a broad term that's existed for, we've referred to for a number of years, and it basically refers to any kind of computational tool that tries to mimic human intelligence. And there are increasing number of applications that are affecting our practice as oncologists and cancer patients today. The main areas we interact with it as clinical oncologists include things like the use of language models to help with clinical decision support or with documentation, or patients also use language models frequently. There are AI models that have been in use for over a decade in the interpretation of medical images, including digital pathology and breast imaging. Uh, Computational models are also being used in drug development, which can speed the process, identify new targets, make that process more efficient. So it's really permeated, I think, through every aspect of oncology, just as it has in our day-to-day lives, outside of medicine. So
Yeah. And you've worked at this intersection of oncology and AI for some time. What originally drew you to this space and how has your thinking evolved as the tools have moved from proof of concept models towards real clinical development? What's changed about how you see this space?
yeah, so I became interested in AI in oncology mainly because I was very interested in computer science prior to even going into medicine. And I did a lot of programming in high school and in college. And something about computer science is just exciting to be able to do things so much faster, more efficiently, more accurately than what we can do as humans. Just it's something that's always attracted me to the field of computer science. And so as I got into medicine and got into oncology, I was always looking for the potential to apply computational approaches to what I patients that I treat in medicine, and patients that I treat as part of my practice as an oncologist. And so I've always looked for those potential intersections. I think each year we're seeing AI get closer and closer to a number of different clinical applications, and there are some that I think we don't think about, like some of the pathology and breast imaging applications. That I'm a breast medical oncologist, and so I don't read the breast imaging. I can interpret it, but I don't provide the formal interpretation of breast imaging, or myself review the pathology slide. So there are some of those applications in the background that are probably the earliest in application. But I think really since probably 2023, with the rise of these language models, I think the obviously AI is such a hot topic in every potential domain. And that's really, and these language models get essentially immediately into the hands of patients and providers because they are published publicly, and they perform so accurately at so many different tasks, achieving performance better than PhD level scientists at relevant science questions. And so I think everyone's drawn to that application of them, and so they've clearly been used heavily across the clinical cancer care spectrum as well.
hmm And you mentioned some of these already. There are already approved tools that can quantify immunohistochemistry, detect cancer on slides, flag metastasis and lymph node resections, things like that. For practice from the practicing oncologist perspective, which of these tools are actually making a huge difference in real world workflows? Because some of them sound like they're still in kind of like in the conceptual phase, and then some are being used heavily. From your perspective, what's really making a splash?
I could give you a shorter answer or a longer
Give
answer
me
to
the
this.
long answer.
Okay. I think we should talk about really what we see in radiographic imaging, pathology, and maybe clinical AI separately. So the radiology sort of AI tools started with what we call computer aided diagnosis, which were less of these deep learning models and more image recognition approaches. And computer aided diagnosis has served as a second reader to mammograms in the United States since the, I think, early mid 2000s. And these earlier approaches had some sensitivity for cancer detection, but there have been several studies of many of those early mammography models that found that led to an increase in number of biopsies, potential inaccuracies, and they weren't adopted worldwide. It's kind of just regional differences in practice, but they were in the background in our practice even for, you know, probably 10, 20 years for patients as they were getting evaluated for breast cancer screening and breast cancer diagnosis. Uh, what we're seeing in the last perhaps 5 years or so are the replacement of these more crude image analysis techniques with artificial intelligence algorithms that are trained on millions of mammograms and can actually improve on the performance of what a trained breast radiologist can do. And what's really exciting is this year we saw the first approval of a breast cancer risk prediction tool directly from mammography. Now, we know that there are mammographic features that predict breast cancer risk, including breast density, but I think it's very futuristic to just imagine AI models learning the features associated with risk from this analysis of millions of images, things that we probably couldn't pick up on with our naked eye, and use that to be able to identify patients who are more at risk, and then perhaps intensifies the frequency of screening and lead to more early diagnosis and more cure. And so these tools are still in I think the AI assessment of mammograms for just the diagnosis of suspicious lesions, they are in practice and are affecting patient care. The risk assessment stuff is something that's on the horizon, and I think we will see in the near future, but that has the potential to do better than our current practice, and I think that has a lot of promise. Um, then when we get to some of the pathology biomarkers that you mentioned, similarly, it's been, probably about a decade that we've had pathology tools that could basically accomplish things that a pathologist could do and just do so maybe a little bit more quickly, maybe in a little bit more of a standardized fashion. And what we're really seeing in the last few years are moving to AI predicting things that a pathologist wouldn't be able to do from a standard H&E slide. So with these tools that you mentioned, like quantifying immunohistochemistry, in general, that's kind of a routine workflow. And actually, at our hospital, we don't employ these AI tools to quantify the immunohistochemistry. Although I know we get referral cases where I'm pretty sure that AI had helped because we get estimates of things like estrogen receptor percentage as like 73%. And pathologists are, most pathologists don't quantify things that precisely. So, I know these tools are in use and are sort of being employed in that fashion. uh they do have the potential, even when these tools are just doing what a pathologist is doing but more systematically or in a more reproducible way, they do still have a potential to provide some advantages to patient care. We saw some data presented at ASCO of a study where they had 100 pathologists reviewing HER2 immunohistochemistry. And pathologists are pretty good at distinguishing HER2 2 plus versus 3 plus, which is the cutoff for HER2 positive breast cancer, from immunohistochemistry slides. And that's what actually the antibody concentration was designed to do. It was designed to be at the range to detect that level of HER2 expression. But with these antibody drug conjugates that work for HER2 low and HER2 ultra low disease, we're now at the lower end of detection of HER2, much lower than the sort of antibody concentration was optimized for. And so there's a lot of discrepancy when pathologists are reading those cases at the low end of the spectrum. But in this study presented at ASCO, they had 100 pathologists read about 20 HER2 immunohistochemistry cases with or without a commercially available AI tool. And they saw much better concordance in that HER2 ultra low and HER2 truly zero category, suggesting that we might be able to more effectively or at least more consistently select patients for some of these antibody drug conjugates directed towards HER2 that we have available today.
Mm.
So they can still have some improvements even when they're just sort of doing exactly what a pathologist would do. And those are perhaps pretty close to being having the potential to be used clinically. Um, especially if you have maybe pathologists that are not, breast specific pathologists, those who are not looking at the breast biomarkers on a day-to-day basis. I think that that has a lot of value to potentially improve consistency of care across the map in the United States as well as globally. But I think what's really exciting is in pathology space, and what we're seeing a lot of in at San Antonio this year are these biomarkers that are identifying things that we wouldn't previously be able to identify. In particular, we've seen a number of studies that are predicting risk of recurrence for early stage breast cancer, either through predicting the genomic test that we use, like Oncotype DX or Mammoprint, or by directly predicting the risk of recurrence. And some of these studies have shown better accuracy at predicting that recurrence risk than our existing genomic risk tools. And so I don't think we're there today, but I think in the near future we'll be using AI pathology-based tools to better risk stratify patients, to be able to improve our selection of patients for treatments like chemotherapy and cell cycle inhibitors. Um, and I think that there'll be continued emerging use cases in pathology as time goes on and as these models improve. And then lastly are these language models. And really, these language models, like I said, as soon as they get published, people are using them. Their open evidence is one of the one language model that I think is highly sort of regarded among physicians because it does a lot of accurate citation of the quotes that it generates. And they have a statistic on their website that 100 million patients in the U.S. will have a provider who uses open evidence in some form. Now, whether that's marketing for open evidence, or, trying to drum up investment, I do think that there's some truth to that, that almost everyone you talk to in medicine has at least used one of these language models. I don't think that they are, um, uh, you know, they I think, in my opinion, they serve sort of like an improved search engine. They're able to pull up a lot of evidence, review a lot of literature quickly, and maybe pull some things up that are relevant for someone to review. There's relatively little known about, despite them kind of just immediately being available. There's relatively little known about how well they perform for oncology specific and breast cancer specific tasks, whether it's for symptom management or for clinical decision making. And so I think we need better standardized approaches to assess these just constantly evolving language models to ensure that, however we're using them, we are using the most appropriate model, and that it's just being employed effectively. And then we can, educate patients, because, patient may see, data about the effectiveness of these models, and turn to them just as they would for other questions that they have about, other issues in their day-to-day lives. They might turn to these models to ask questions about cancer treatment or their cancer diagnosis. And, we need to be able to provide patients information about what they should be using. Um, these language models are being employed throughout health systems for other tasks, like to automate documentation, to better match patients for clinical trials. The use cases are endless, but I think we are seeing an evolution in how these models are being employed today.
It's fascinating. I want to go back and kind of touch on some of the things that you brought up. Let's start with just touching back on the image-based AI outputs. How close are we, or what gap still exists, in your opinion, that's preventing us from routinely using image-based AI outputs, such as digital biomarkers, alongside or even instead of traditional pathology features in tumor boards and treatment discussions? What is the bridge that we need to cross to really make that happen?
I think that there are a few things that are needed, and it comes back to kind of the same level of evidence that we use to evaluate traditional biomarkers, in that you need to have a model that you have sufficiently validated that you can trust that its output will provide you an accurate prediction of the endpoint that you're trying to predict, and that its performance has to exceed what you currently have available. I mean, they have potential applications where I think that people are exploring their use in, for example, if we have a biomarker for Oncotype DX that is 90% accurate, maybe that is sufficient in settings where Oncotype DX and genomic testing is just too costly. And so that's one area where they're being explored and potentially may soon be deployed. But when we think about applications in high resource settings like the United States, I think we really need to demonstrate, one, sufficient validation of whatever tool we're talking about, and that the performance is better than our current standard practice. And this can be done in retrospective studies, but it requires that you have already trained your biomarker, so you have something that is a little bit mature, that you have this biomarker that you lock down, and then you pre-specify what you think you're going to find. That you're going to find that it predicts benefit for chemotherapy or can identify who needs to have extended endocrine therapy, and that just takes a little bit of time. There are there are, you know, probably dozens of companies that actually have models that are in commercial development, several of which are actually clinically available that you can order in the United States and Europe. But adoption, I think, is going to depend on this sufficient validation. And when we see these biomarkers that are being made available, actually, we even see, I've seen some work here at San Antonio this year of biomarkers that are newer versions of ones that people had published or presented a year or two ago. From some of these commercial groups. And so it also requires, when you have that newer version and you continually update your model, it makes it hard for a provider to trust and know if the use scenario is just the model was optimized, and then they updated and just chose one that worked well in one specific validation set, or if it's really going to perform well across the board and in real world settings. So it really requires that you're confident in the model, you lock it down, and then you test it for that outcome of interest in a retrospective cohort and prove that it performs better than how we currently make decisions, which ultimately is going to come down to a comparison to, in a lot of these cases, genomic tests for early stage breast cancer. It may end up being that there may not be a perfect validation set for some of these cases, like Oncotype DX. Many of the studies that evaluated the ability of Oncotype DX to assess chemotherapy benefit in higher risk patients um, were conducted in the 2010s, studies like NSABP-B20. There was a study from SWOG, and uh, are also a little bit outdated compared to current practices. Some of these models, like some of the work we've seen at San Antonio this year, are models tested in more recent studies like Taylor RX, which and some of these have very promising performance, but that study it was essentially a study that found that in the population that was randomized to chemotherapy or hormonal therapy alone, there was no difference. So the population evaluated in that study, it's not going to be able to prove that your histology-based marker is predictive, for example, of chemotherapy benefit. So then you run into, do you validate an older study that's potentially outdated? If you show that, will everyone trust those results? Or will it require actually a new study? And I think that we actually may enter this era where we have a study where patients are randomized to get treatment based off of a genomic test versus an AI-based test once sufficient data accumulates, and then if we demonstrate that the AI test is as good or potentially even better, then I think we'll see an even more dramatic shift towards the use of these tools. Because even if it's just as good, the AI tests are immediately available from H&E slides. They don't require a lot of tissue to perform compared to genomic testing. They can be done much more cheaply, although the companies making these tests are billing, even though it's just really running an algorithm on a slide, it still gets billed in some of these cases for almost $1,000. So it's still not cheap, but maybe cheaper than genomic testing.
Mm. And there's a lot of excitement around using AI to better identify HER2 low breast cancer compared to traditional IHC scoring. What are the limitations of current uh, HER2 classification, and how might quantitative AI approaches improve patient stratification for HER2 targeted therapies?
Yeah, that's a great question, and kind of gets back to, as I mentioned earlier, the current HER2 immunohistochemistry assays are optimized to distinguish HER2 2 plus from 3 plus cases, identifying those that are more highly HER2 amplified, what we've traditionally called HER2 positive breast cancer, and are really not optimized to distinguish lower levels of HER2 expression. David Rim's group has done a lot of the analysis demonstrating pathologist discrepancy and categorizing some of these lower groups of HER2 expression. So it's kind of a matter of just this assay was not optimized for distinguishing HER2 expression at those lower levels. Um, I think that as the study that I mentioned from ASCO demonstrated, these AI approaches at least can improve consistency by doing this in a very rigorous, systematic, and automated fashion. There have been other studies that have shown that the AI quantification can correlate with, for example, HER2 mRNA expression at lower levels of this HER2 dynamic range than you might expect from a pathologist reviewing these slides. And I think it's that more precise quantification that would allow for more precise HER2 stratification to identify those HER2 zero from ultra low patients who currently have an indication for HER2 directed antibody drug conjugates. Um, there's another sort of related question is do we need to quantify HER2 better at the lower end of this range to identify the patients appropriate for this treatment? There's a study, again, David Rim is doing the correlative work for the study called Quantify Her that's using quantitative immunofluorescence to capture HER2 expression at the lower end of the dynamic range. So perhaps a different assay or, the AI approach will allow us to better identify patients at this low end of the expression range who may benefit from HER2-directed therapy. On the other hand, there's also an open question, and there's an interesting clinical controversies at San Antonio this year on are antibody drug conjugates targeted therapies or are they not? And so there's some debate on at this low level of the expression range, is the uh, is the efficacy of the drug really because it's binding to some of that HER2 protein on cancer cells and releasing the payload? Or are there mechanisms of payload release that are independent on tumor antigen expression? And there's a few potential mechanisms, such as release of lysozymal enzymes into the microenvironment that might cleave the payload, even if the tumor doesn't have antigen expression. You get a high amount of payload that's in the circulating bloodstream. And so this is detailed more in this controversy session, which would be good to, for people who are interested, I definitely encourage watching it. But if ADCs are not as targeted as we think, especially at the low end of this expression range, then accurately quantifying it will HER2 expression at that end of the range won't help us select patients better for treatment. So I guess we'll have to see.
What guardrails would you want in place before using an AI driven HER2 low classifier to change treatment decisions, such as offering or withholding antibody drug conjugates?
Um, that's a good question. Let me think about that for a second. I think the ideal cutoff for identifying a patient for HER2 ADC is going to be one that has some type of predictive value. And so far, we don't actually even know if HER2 low, like the low end of expression range, the ultra low, sorry, is predictive compared to HER2 non-expressing. We don't actually have a sufficient group of patients with HER2 truly zero versus HER2 ultra low to know if at that low end of the HER2 expression range, that identifying those HER2 ultra low cases more accurately will allow us to better select patients for treatment. And so ultimately, what I would like to see, I'm not sure if we'll ever have this, is a comparison of these stratifications by different modalities and potentially different vendors. There was another interesting study recently published in Modern Pathology that had that compared many of these commercially available HER2 immunohistochemistry softwares, and found that they can perform accurately, but there's actually a lot of discrepancy when you compare one software to another. And so the question is, what is the gold standard? Is it a pathologist assessment? There's a lot of inaccuracy between pathologists. Could you use some alternative biomarker like mRNA? But I think that for patients and as a clinical oncologist, the thing that matters most is, can you identify the patients that respond to the therapy, and what is the best tool to stratify patients who would respond or who wouldn't respond? Um, right now, since I'm in favor of, I want to have the most number of shots at goal for a therapy for a patient. I guess I would want to have an assay that's going to be the most sensitive to allow me to at least have the therapeutic option for drugs like Enhertu for the most number of patients. And so I would want to make sure that the assay was at least as sensitive as kind of our pathologists. But we currently don't use these tools in our clinical practice. We have great breast pathologists in our program. And so I think it would require some data really showing that we can use this to improve selection of patients for treatment for
Mm.
me to adopt it.
Wonderful. I want to swing to a different direction a little bit and talk about ethics and governance. What are the biggest concerns that you hear from clinicians, administrators, and legal teams maybe when it comes to deploying AI in breast cancer care?
I think a lot of the big concerns come from the use of language models. One concern comes that uh, when you access a commercially available language model platform such as ChatGPT, and you provide information into that platform, it goes into the cloud, and it even if there's options to say have a temporary conversation where it's they say they'll delete conversation data, some limited amount is retained. It's not truly HIPAA compliant and protected, and so you have to be very careful about what kind of data that you're putting into the models and make sure that you're compliant with you're not sharing any PHI with the models. I think that's definitely a big concern of hospitals and hospital administrators. So much so that our hospital, and as well as I know several others, have internal versions of some of these language models that are hosted on their own servers from a prior model checkpoints, so that they can control the flow of data to ensure that we're not uh, inadvertently sharing patient data inappropriately, because we might look you could imagine you could look up get some information about studies relevant to a patient's treatment, and if you accidentally provide a little bit too much information, that's going to be a big problem. um, Another challenge is with regards the language models are inherently there's a randomness inherent to how output is produced for language models. And so that essentially guarantees that you're going to get some inconsistencies, even if you provide the exact same prompt multiple times. And uh, this, again, they could be helpful tools, but in the same way as for many of the computer aided diagnosis for a radiologist, they might suggest lesions that are suspicious. The radiologist ultimately has to review those and make a decision based on their own expertise. Make sure that it's not related to some artifact or something else that is inappropriate. And similarly, I think any kind of recommendation from some of these language models that are in use has to be vetted with a clinician's own expertise. And there's not going to be a legal argument to say, well, ChatGPT told me this was the best strategy. That's gonna you can't do that. You'd be in trouble. Um, Another kind of related, I think, ethical issue is there was an interesting study that showed that um, one non-oncology use of AI, or is like kind of more peripherally related, is the use of AI for endoscopy for colon polyp detection. And there was a study that found that after use of some of the AI models to improve colon polyp detection, that gastroenterologists, if they stopped using that AI support, kind of was helping them, that actually their detection rates would decrease to below what they would have been before using that technology. And so I think that's kind of another concern. And I mean, that's a concern, I think, across education, the whole educational spectrum. Our is over reliance on AI going to degrade our critical thinking as well as our own knowledge base? Um, that's kind of a theoretical concern. I think that I think we have to, in the end, accept that AI is here. It's going to impact how everything is done, including in medicine. And uh, rather than um, avoiding its use or putting our heads in the sand, we have to understand what are the biggest areas these models can make a difference, how to use them responsibly and appropriately. And I think ultimately that'll lead to better outcomes for everybody.
Speaking of the biggest areas where these models can make a difference, looking into the future, what is your kind of dream area that you hope to see more research done or more work done when it comes to artificial intelligence and oncology? Is there anything that you're super excited about more work being done? Uh,
I'm particularly, I mean, this may be motivated by my research focus, but I'm particularly interested in continuing to explore how digital pathology as well as multimodal data can help us to better personalize treatment. As similar to the era of when gene expression technology and sequencing technology became more widespread, we were able to better distinguish different expression-based subtypes of breast cancer that has formed the foundation of a lot of science that we've gotten that has brought us to the current day. And I think that similarly, we can gain uh, sort of somewhat related but also distinct insights about biology from digital tumor images that will allow us to, like I said, I think in a few years we've seen a lot of this interesting data today, but I think in a few years we will see digital pathology risk tools that potentially perform better than our existing genomic testing, and then using these in an orthogonal fashion will allow us to better select patients for chemotherapy, and better select patients for the many other therapies that are in development today, cell cycle inhibitors, and other targeted treatments. Um, I think that one of the biggest barriers or the challenges here is that accessibility to data. And I'm a big believer that we need to have robust data sharing to ensure that we can work together as a scientific community to understand mechanisms of response and resistance to treatment that can only be learned from analysis of many, many patient samples. And I think that I don't have a solution to that, but I think that's kind of a challenge to the research community. I think that thankfully most of the large academic oncology cooperative groups are very good at this and are enabling the development of many of these next generation tools. But when it comes to a lot of the drug development is also done by drug companies who do a lot of great correlative science and also make the next generation of therapeutics available to patients. But I do think that whether it's federally or in some other way, um, accumulating data from vast number of patients across multiple dimensions, digital pathology as well as genomics and others, will allow us to build models that really help us to be able to select right treatments for the right patients, um, to allow for really personalized precision medicine. Because we've talked about, I think, precision medicine for in oncology for a long time, and still so much of the treatment that we give is really based off of very broad groups of patients. And I think a lot of that is due to if we could get the data. I think that's the biggest challenge facing AI is to get enough data to build the models that we need to answer the important clinical questions. So I think we are making progress. There's a lot of different initiatives that will facilitate this progress, but I think uh, as we get better data and multimodal AI, I think we'll start to see how much it can be integrated into patient treatment.
Wonderful. Well, this has been an amazing conversation. Dr. Howard, thank you so much for joining us here on MD Newsline Podcast. It's been a pleasure.
Thanks again. It's been a pleasure.